All right, today we're tackling a big one, slipped capital femoral epiphysis, or as we all know it, SCFE. This is one of the most common hip problems in teenagers, and for any orthopedic trainee, this is a topic you absolutely cannot get wrong. A misstep here can have some really serious consequences. So we're going to walk through it all with a structured approach that'll have you ready for your exams, and more importantly, for your patients.
So let's just jump right in and look at the heart of the problem. On the left, you've got a normal, healthy hip. See how that ball, the femoral head, sits perfectly on top of the femoral neck? Now look to the right. That's SCFE. It's like a scoop of ice cream sliding off the cone. That head has slipped off the neck. And this break, this failure, happens right through the growth plate. Understanding that single mechanical fact is the key to unlocking everything else we're about to discuss.
So here's our game plan. We'll start with the fundamentals, then we'll move into what these patients look like in the clinic and how to examine them. After that, we'll cover radiographic diagnosis, how to classify the slip, the principles of surgery, and we'll wrap up with the major complications and the biggest takeaways.
Okay, first things first, the fundamentals. Before you can even think about treating SCFE, you've got to understand the who, what, and why behind the slip, who gets it, and what's actually happening on a mechanical level.
Let's break down the textbook definition because every single word here matters. It's a posterior and inferior slippage, but here's the interesting part. The head, the epiphysis, actually stays right where it is, inside the socket. It's the neck of the femur, the metaphysis, that moves forward and rotates out. And the failure point? It's always in the hypertrophic zone of the growth plate. That is the weak link in the chain.
So who walks into your clinic with this? Picture the classic patient. A teenage boy, somewhere between 10 and 16, right in the middle of a big growth spurt. Now, the single biggest risk factor, and it's not even close, is obesity. We're talking more than 60% of these kids are over the 90th percentile for weight. We also see it more in certain ethnic groups. It tends to affect the left hip more often, and you have to remember this, it can happen on both sides in up to half of all cases.
You might be wondering, why adolescence? What's so special about this time? Well, it's basically a perfect storm of mechanical weakness. That hypertrophic zone in the growth plate becomes incredibly vulnerable. The little protective ring around it gets thinner. The growth plate itself becomes more vertical, which just invites more shear force, and all the little interlocking parts that normally provide stability, they start to unlock. The whole structure is just primed to fail under stress.
Now, while most cases are what we call idiopathic, meaning we don't know the exact cause, you have to keep your antenna up for underlying conditions, especially if the patient doesn't fit the typical picture. You see a kid under 10 or one who's actually underweight, say below the 50th percentile, that's a red flag. An endocurrent workup is a must, and the most common culprit you'll find is hypothyroidism.
All right, so we know the who and the why. Now let's talk about the how. How do these patients actually present to us? And what are those classic telltale signs on physical exam that should make your spidey sense tingle for SCFE?
The symptoms can be super vague, which is part of the challenge. Yeah, most patients will complain of hip or groin pain. A lot will also point to their thigh. But here it is, the classic pitfall you can never, ever forget: isolated knee pain. The obturator nerve is tricky. It sends referred pain from the hip straight down to the knee. This means up to half of these kids will show up complaining only about their knee. This is how these diagnoses get missed.
So what about the physical exam? Well, the pathognomonic finding, the dead giveaway, is the Draymond sign. As you passively flex the patient's hip up, you'll see the thigh just automatically drift out into abduction and external rotation. They're not doing it on purpose, it's an obligatory move. It happens because that displaced front part of the metaphysis is bumping into the rim of the socket. You'll also find they can't internally rotate their hip very well. That's probably the most sensitive sign on exam.
Okay, so your clinical suspicion is high. Now you need imaging to prove it. And we're going to focus on one tool in particular, a simple line on an X-ray that was a total game changer for catching these slips early.
Meet Klein's line. It's incredibly simple. You just draw a line along the top border of the femoral neck on a standard AP X-ray. In a healthy hip, that line will slice through a piece of the femoral head. But in SCFE, because that head is slipped down and back, the line will just skim the top of the head, or miss it completely.
And this is why this line is so important. This quote from Dr. Klein's original paper back in 1952 really gets to the heart of it. They were seeing the awful, crippling arthritis in adults who had a missed SCFE as a kid. They knew the only way to prevent that was to catch it early. Klein's line was invented specifically to find those subtle slips before they became a total disaster.
And this X-ray shows it beautifully. Take a look at the patient's normal right hip. That's on the left of your screen. See how Klein's line cuts right through the femoral head? Perfect. Now, look at the other side, the affected left hip. The line completely misses the head. It just sails right over it. That asymmetry is the classic sign you're looking for.
Now, Klein's line is fantastic, but it's not the only thing to look for. The frog leg lateral view is actually your best friend for spotting a very subtle slip. You can also look for something called the metaphyseal blanch sign of steel on the AP view. It looks like a blurry double density. Or you might just see some widening of the growth plate itself.
Okay, great. You've used your exam skills and imaging, and you've confirmed the diagnosis. The next step is absolutely vital for deciding what to do next and for understanding the prognosis. You have to classify the slip.
By far the most important classification system is the one from Lauder. It's based on one simple thing: stability. And it comes down to a single question: can the patient walk on it? If they can bear weight, even if they need crutches, we call that a stable slip. The risk of major complications is low. But if they absolutely cannot put any weight on that leg, that's an unstable slip. And that's when the risk of the femoral head losing its blood supply just skyrockets.
And look at this number, a 24 to 47% chance of avascular necrosis. That means there's up to a 1 in 2 chance that the femoral head could die. This right here is exactly why we consider an unstable SCFE to be a true orthopedic emergency. The clock is ticking.
So Loader tells us about the immediate risk. The Southwick classification, on the other hand, is how we measure the actual geometric severity of the slip. You measure it on the lateral X-ray, comparing the angle of the slipped head to the normal side. This helps us grade the deformity as mild, moderate, or severe, which can be important for planning future surgeries.
So we've diagnosed it, we've classified it. Now what are we going to do about it? The primary goal of surgery here is actually pretty simple: stop it from slipping any further. We want to stabilize that hip. For almost all of these cases, the gold standard treatment is percutaneous in situ fixation. The absolute #1 rule is no forceful reduction. Trying to crank the head back into place can tear the delicate blood vessels. So instead, we put in a single large screw right across the growth plate to lock it in place. You want that screw right in the center, perpendicular to the growth plate, with plenty of threads across the physis for a solid hold. And of course, you have to be absolutely sure it doesn't poke into the joint. So even with a perfectly placed screw, there are still long-term risks we need to think about. Let's finish up by talking about the major complications and then summarizing the most important points to take away from all this.
Okay, there are 3 big ones you have to know. First, avascular necrosis, or AVN. This is the one we fear most, and it's almost always tied to those unstable slips. Second is chondrolysis, which is this rapid, mysterious melting of the joint cartilage. It can sometimes be caused by a screw that pokes into the joint just a tiny bit. And finally, you can get femur acetabular impingement, or FAI. This is basically because the hip is no longer perfectly round, and that misshapen joint can lead to early arthritis down the road.
And we'll end on this question, because it really captures the single most important lesson here. Why do you have to, without fail, examine and x-ray the hips of any kid who comes in with knee pain that isn't from an injury? Because, as we've seen, that's how up to half of SCFE cases will try to fool you. Forgetting that simple rule can mean a misdiagnosis, a worse slip, and a lifetime of hip problems for that patient. So if you remember nothing else, remember this: in a kid with knee pain, always think of the hip.